hopefully we'll understand the difference between the different advanced care plans, pulse and code status, and maybe one is more important than the other. Realize the importance of end-of-life conversations, the why it's important, why we should all be doing ACPs from 18 and up, and why we should talk about death. Hopefully we'll learn some tips on navigating these conversations that we'll be able to dig deeper into aligning care with the goals of our patients and the patient priorities and what matters to them. And resources. I think the biggest thing I can leave you with today is resources and places to go to learn more. And I think, before we get into that, this is my grandmother on the slide here. She died at 107. And even though she was 107, she didn't want to talk about death, right? I mean, it seems strange to me that she would be 107 and know that death has to be knocking on her door. But our society just does not ever want to talk about death. So it's hard. That's why it's hard. Nobody wants to talk about it. Even her family, she had 4 kids. My father was one of them, and they didn't want to imagine her dying. Even though she was 107 and had lived far beyond her years, right? And so it's just, nobody wants to talk about these things, but we should, right? And so this little section here is a blurb from Dr. B.J. Miller. He is a palliative care doc in San Francisco, and he has a really great TED Talk that I have in my, at the ending here, a great thing to go watch. And he wrote this little piece that has that this is quoting from during coronavirus in the New York Times. And he has a unique background in that when he was, I think roughly, it's been a while since I watched his TED Talk, but when he was roughly 18 years old, he was playing with I guess 18, you're not playing, you're kind of messing around with your buddies. And it was late one night and they were in one of the electronic bus stations or something like that in San Francisco, and they climbed up on top of the bus. They were in the parked yard, right? And he reached his hand up and his watch hit the electrical current that was up above that was the energy source of the buses, and it sent the electrical current through his body, and he ended up losing his arms and legs, but he lived. And so he then became a palliative care doc, and he just has some interesting insight from his lived experience. And so he talks, why do we need to talk about this? Why should we talk about death? And or should we talk about what's living, right? So what is death to a lot of us in the medical field? It's no heartbeat, no breathing, no brain function, being brain dead, which requires an EEG, right? For some, and everybody has a different opinion, death is reached when all other loved ones have perished, or when we can no longer think straight or go to the bathroom by ourselves, or have some kind of sex, or when we can no longer read a book or eat pizza, when our body can no longer live without the assistance of a machine, when there's absolutely nothing left to try. Maybe the most useful answer I ever came across was the brilliant professor who instructed his daughter that death was what happened when he could no longer take in a Red Sox game. So death is different to everybody. And I think that brings us, because what is living? What is quality of life? So talking around death and quality of life is the best that we can do to reach an understanding of what matters most to our patients. We're always left with the next biggest question, one that's answerable and more useful anyway. What is death to you? Because it's different to everybody. When do you know you're done? What are you living for in the meantime? We have fuller ways of knowing. Who doubts that imagination and intuition and love hold power and capacity beyond what is language can describe? You are a person with consciousness and emotions and ties. You live on in those you've touched in hearts and minds. You affect people. Just remember those who've died before you. There's your immortality. There in you they live. Maybe this force wanes over time, but it is never nothing. And I think watching his TED Talk and reading this full, you can go and read the full article that he wrote, and just knowing his background, I think it also can change, right? So what you may think is living today may change, 2 months from now. An 18-year-old probably thought it was not living to not have an arm and legs, but he learned to change what his idea of living was. So I think it's an ever changing, which was what makes it so hard to have. It's not one conversation and you're done. It's something that is you're constantly having those discussions with people, and it can change. So I think when we're talking about death, we should ask a couple of questions. Where do people want to die? What is their desire? And studies have shown that approximately 80% of Americans would prefer to die at home if possible. And does that actually happen? No, 60% of Americans die in acute care hospitals, 20% in nursing homes, and only 20% at home. So a very minority of patients who are dying use hospice care. And even those patients, it's a last minute referral, and they don't get the full benefit that they could have. They die within days to weeks of being enrolled in hospice. Not every patient wants to die at home. And I think a lot of this comes from personal experience. I can think of some patients who say they definitely don't want to die at home because they were there as a child when their grandmother died, and it was an experience that they don't want to inflict on their grandkids or their kids. So there's different experiences, I think, shape our thoughts about death. Depends on culture. Certain cultures, they don't want to die at home, and so we have to know. Sometimes it's a burden on the family, so helping them understand that we can get help with hospice care at the end of life, or what options are there. But I think you have to ask that question. What would you want it to look like, right? But we aren't asking it enough because it's not happening. What people wish for is not what's happening. So why is that the case? And I think we probably all have ideas on this, and it's a little piece of the puzzle. But why do people still die in hospitals if the majority of us don't want to? And it's a lot of things, right? Death is unpredictable. Because we go in when something's wrong and we hope it can be fixed, right? And maybe we overestimate the ability of medical care to cure our illness or reverse it. It's a lack of alternatives. If something happens and I'm in distress and need help, is there a different option for me? So a lot of times we're stuck in hospitals. It's hard to get into TCUs or hospice houses or other places to go that can support us. The culture of medicine and availability of medical care. So, and throughout training as a physician, we're taught that we're supposed to diagnose and treat. We have to keep doing something. We have to figure out what's wrong and we have to fix it. And we aren't taught about what to do when there's little to do to treat. And we aren't taught as well, although better now, I think. There's geriatricians, there's palliative care docs, and so hopefully we're doing better at teaching these things, but giving alternatives, right? And I think when people are in distress or acutely ill, it's stressful and scary, and they're anxious, and so even if you are on hospice or you have a plan in place, an ACP that says you don't want to die in the hospital, we do that because we want help for our acute symptoms. I think doctors aren't good at talking about what our next treatment will do. We have come up with a lot of new treatments. TAVRs are the big one I see in a geriatric practice, right? So even frail people can get their valve replaced. We don't have to do open heart surgery. We can do it through the groin. And we keep doing things to fix things that were our quick kind of our quick death, sudden death. But does that leave a good life left? And I think those are all questions we need to think about and talk about and speak with our patients about. Let's see, encourage patients to have inpatient treatment with little chance of changing the long-term outcome because we're overly optimistic about the prognosis. I think there's often, I don't know whether it's medical error, misadventure, I like better, where critically ill patients have limited capacity to tolerate the downsides of medical treatment, and we don't realize that. Our healthcare systems focus on the short term and not on the long term. And so we treat and acutely make things a little bit better, and then where do they go? But going back to what people's wishes are, if you talk to the majority of people about what they want their death to look like, you know, what do I want my death to look like? I want to live at the highest function possible and go to sleep one night and peacefully fall asleep and not wake up the next day before I become disabled and crippled and dependent in my activities of daily living, right? But what is most likely to happen to me is the majority of us, I think it's 94, 96% of us will spend the last 4 years of our lives requiring help with at least one ADL. So that's dressing, toileting, bathing, eating, right? 4 years of our life will continue this gradual decline or prolonged death, it's been called too, right? And that's what the majority of us will expect. Even though if we ask what people would want it to be, they would want that kind of sudden, quick, peaceful death. I think why again do we not get the deaths that we want, right? I think a lot of times transitions of care are fragmented, so we may have a good plan of care in the assisted living facility, a good advanced care plan, but when we get to have an acute problem and they send us into the hospital, that advanced care plan doesn't stay with us, or it's not reviewed by the medical team giving care in the hospital. I think, and we'll talk a little bit later about its language that we have. The first thing we do when somebody's hospitalized is, instead of looking at their advanced care plan that we have documented and knowing that they've been, you know, DNR in the past, instead of saying something like, I see in the past you've been do not resuscitate, so we will plan to keep that course of action, but do everything we can to improve your lungs and get you home, right? Instead of that, we say, do you want CPR or not? Right? It's more conversations like that are had than yes, no questions, instead of discussing what we've seen happen in the past and how would you like to proceed from here? Should we be consistent with your wishes? I think patient example. So my own grandfather, we'd had multiple conversations with him, and he had expressed his wishes to limit hospitalizations, to not want CPR at the end of life, but to go peacefully when his body was giving out. And he'd been in and out of the hospital multiple times. Every time he got into the hospital, they would ask him again, and he would say, oh yeah, do CPR. And we'd have to stop him, my mother or myself, and say, hey, Grandpa, we've talked about this and you don't want that. And I think a lot of it is people get the feeling that if they don't say they want everything done, then we are not doing everything to reverse their care. So I think a lot of it is language and conversation. And last time I gave this talk, the person that was giving it with me talked about even her own father. So she was an advanced care planning nurse, and her own father or mother was admitted to the hospital that she worked at, and nobody would listen to his prior stated wishes. I mean, they had to fight so hard to do what his documented wishes were, instead of the course of action that they had laid out and wanted to do. So we lay it on the family to make these decisions and we aren't good at reviewing advanced care plans if they've been done. So language matters, and there was just came out in the Jerry Pale podcast. If anybody's listened to that, it's a very good podcast that a geriatrician and palliative care docs run, and they have speakers on all the time. And this particular one that just came out fit our kind of conversation, and it was three speakers came on, and two of them were the ones that had written these recent articles. And one you can find in the JAMA is called Reconsidering the Language of Serious Illness. And Jacqueline Cruiser is I believe, a ICU doctor. And then The Hidden Harms of CPR was written in the New Yorker, was just out in the New Yorker, and it was by Sunita Puri. And here's some just excerpts from those, and the conversation that they had on the Jerry Pale podcast is really great, and I'd refer you to listen to that too. But it's all about the language behind how we talk about things. And their main topic was when you have acute serious illness in the hospital, and so acute care and hospital ICU care. But the one topic was about conversations regarding CPR. And we know there's been recent studies done that showed, one for the VA, in the VA system, that showed that asked what people's thoughts are CPR, and something like 80% of them said they wanted CPR when it was described, or what they knew, what was in their head from what they knew from media, right, and movies and TV. And so 80% had said they wanted to do CPR. And then they showed them a 3-minute video of actual CPR being performed. And afterwards asked the same questions. And I think it went down something to like 30% then agreed to have CPR at the end of life. So I think getting an accurate description or portrayal of what CPR is important. And the language we use is important. So if you say, should your heart stop beating, do you want CPR to restart it? So everybody's like, yes, right? I mean, if you were asked that question, who wouldn't say yes to that? But it is because of their unrealistic ideas and expectations about success, and that's from movies. And then from Damar Hamlin, the football player who recently was, an example of the perfect scenario, right? So I think you have to have those conversations. It's not like you're not Damar Hamlin. You aren't the top of your physical, health, and it was just a heart, arrhythmia that puts you into needing CPR, but everything else was perfect, right? You're here with chronic medical diseases, and your heart's going to stop because of other reasons in general, right? So being realistic and having realistic conversations about what CPR is, and it's how well we do, right? So a mere 2% of adults over 67 with severe chronic disease, including cancer, are alive 6 months after CPR. So 2% above the age of 67 with severe chronic disease, including cancer, are alive 6 months after CPR. And they often deal with pain, physical disability, and post-traumatic stress disorder. So reversing a death is not the same as restoring a life. And I think that's a profound statement right there, right? Reversing a death is not the same as restoring a life. And if we use kind of that language, I think it can help in making more informed decisions. And again, the unrealistic on-screen portrayal. So the result done correctly is akin to assault. The force of compressions can shatter ribs and breastbones, puncture lungs, bruise the heart, and cause major blood vessels to rupture. Repeated electrical shocks can burn flesh. Even if the procedure restores a heartbeat, brain damage, whether mild memory loss or a vegetative state, occurs in 40% of hospitalized patients. So I think just being realistic is important, and having those realistic conversations. So just a quick review, kind of changing directions a little bit, the quick review of the different types of things that are out there. One's just a DNR order. So it's a medical order when you're admitted to the hospital. I can put them in for people in the nursing homes, right? Or assisted livings where they sign a sheet. Do you want CPR or not? Or code 1, code 2, right? All those different words are actually a medical order. So when should it be used? For those who are critically ill and do not want CPR attempted when close to death. You don't have to name the decision maker. It communicates specific decisions about preferences to attempt resuscitation in light of current state of health, so it can change, right? Reviewed during inpatient stays and on all admissions. How we do that, I think, though, is important. So, right, it has to be discussed with change in a move to a nursing home or an admit to the hospital, but how we have those conversations, I think, matters. It's filled out by attending provider after discussion with the patient family or from a previous order. It's valid during the current admission once the physician signs. It's not signed by a patient agent. It is, though, used in some assisted livings. They have a form that the patient does sign for in those facilities for their time living there. Pulse, I like Pulse. They have national Pulse, they have state Pulse, and they all have a little bit varying language, but it's also a medical order. And I like to use it if somebody's, in the last 1 to 2 years of life. So if they have multiple chronic diseases and are declining, if they're frail, this is a good time to insert a pulse. And it also doesn't have to name a decision maker, although if you have a designated decision maker, it is usually on there and indicated or noted. It communicates medical treatments specific to a current state of health, and asks questions more like intubation, CPR, what else? So do you want dialysis? Do you want IV antibiotics? Those kinds of questions, a little bit more specific. Do you want hospitalization? Do you want comfort cares at home? Do you want everything? Do you want in between a trial of some of these things? But if it's not working, to stop those things, so you have a little bit more say. And I think it's outlined a little bit better for the medical community to initiate or to follow their rules is a little bit easier than an advanced care directive or advanced directive or advanced care plan. Let's see. So advanced directive or advanced care plan is a legal document, and it should be for anyone 18 years or older should consider one. And it names a decision maker. So if I can't speak for myself, I name my husband, Ben, to speak for me. And it communicates that we've had this discussion and he knows about it, but it communicates on the paper, if I'm in a persistent vegetative state, he's not to keep me alive by extraneous means. It's a little bit vague, right? Because most of the time it says if 2 or more physicians declare that it's a non-reversible issue, then we'd take away treatments type of thing. So it's hard. I think it's hard for physicians in a hospital and acute setting to know exactly how to abide by it. The patient fills it out, and it's valid when the patient signs it. It's usually a witness or a notary. So that's kind of the difference between kind of the documents we have. And here's just an example of the pulse form. So, right, it does ask CPR, attempt or don't, and the comfort measures versus limited interventions versus full treatment. So I like that. I think patients, it's easy to have a conversation where you split things into 3, like full, we're doing everything. You're going to have that big surgery. You're going to have a bypass. You're going to have surgery to remove this cancer. We're going to do everything, try everything. And then comfort measures only. And then the middle one is in between, right? So I think it's a really helpful form, especially for people with multiple chronic diseases who are in their older stages of life. Or if they're younger and just have a chronic disease that is progressive. Here's just examples of advanced care plans and the question it asks, which it tries to get at what matters most to them, right? These are all good questions when you're trying to get a feel for what living means to the patient, and what living, what you are worth, what is worth living for versus what I wouldn't want to live if that was going to be how things were, right? So it's questions to try to get around that. It's up to interpretation though, and so that's what I think makes it hard to go by as a medical provider. So lots of questions: religious faith, significant health problems, what are they? Considering future medical treatments, what would you want to happen to you? And I think it has a lot more here. It also talks about who's your surrogate, who's your proxy, do I want CPR? It also asks if I can no longer make decisions, I will not recover, do I stop or withhold all treatment, or all treatments recommended by my healthcare team? Some of these things make it vague, right? Because what does your healthcare team believe? But my beliefs about when life would no longer be worth living, my thoughts about specific medical treatments, my thoughts and feelings about how and where I'd like to die. These can be really great. I think the times that they're really helpful are when somebody has unfortunately had to live through the situations we're thinking about, right? So they had a brother who had a stroke who then could no longer communicate. And so they have very, very strong thoughts and ideas about, if that happened to me, I do not want to be kept alive. I saw what my brother went through, right? So these tend to be very, very helpful when people have been through situations that give them strong ideas going forward. But if people have never had those experiences, then they typically don't have a lot of strong feelings and can't give a lot of guidance. So then it is up to us to help them get there as healthcare providers, right? And having those discussions, what brings you joy, what matters most to you, what makes life worth living, what are you willing to live without and still feel life is worth living, what are your biggest fears and concerns, and what is your current understanding of your situation and potential outcomes. The Jerry Pelz is also doing the next in the series that I was talking about is going to be on medical decision making and how using percentages isn't helpful, but there was a study done that says best case scenario, worst case scenario is often much more helpful. And so that would be also a good one to listen to. But I think getting at what do they understand are the possible outcomes. So what's best case scenario, worst case scenario, and are you willing to live with those risks and or benefits, right? What goals are most important to you? What trade-offs are you willing to make and which are you not? So those are some good conversation starters to try to get at what matters most. And positive outcomes when wishes are honored. So if anybody has any negative outcomes and from situations like this that they want to talk about because of poor conversations, or if anybody has any positive outcomes because wishes were honored and we had good conversations, I'm up to listening to any. I can tell you when my grandmother, even though she would not have discussions, she did at 107 fall and fractured her pelvis and was hospitalized. And we knew that this was kind of going to be her downward slide. And so we got her out of the hospital as fast as we could because we knew that was the worst place for her. And we took her home and we got everything in place to take care of her at home. And she wasn't hospitalized again. And even though she hung on way longer than any of us would have wanted, because it wasn't the best couple of months, we still, I think, honored her wishes, not poking and prodding her at the end of life, and she had a peaceful exit at 107. But it was hard to get there, I have to say, because nobody wanted to talk about it. So I don't know if anybody else has any comments.
And feel free to put that in the chat too, if you like.
You can, I'll let you think of some more, because I think it's really helpful to hear about both positive and negative outcomes because of these conversations and wishes. Getting more at what matters most, I think, even besides end of life wishes. I like to give example of these two patients. So they're both in their 80s with multiple chronic diseases, males in and out of the hospital. One with heart failure, COPD, and GI bleeds. And we've had multiple conversations, and he knows he doesn't want a colonoscopy for his GI bleeds, so we kind of just monitor his blood counts and give him blood transfusions and perk him up a little bit. So he knows he doesn't want a lot of invasive things, and he is a candidate for hospice. He doesn't want hospice. But what matters, when I ask him what matters to him, he wants to live for 2 years, because that's when his grandson would get back from Japan and he could see him. He wanted to see his grandson in person again. And so we said, okay, well, you're not DNR, you don't want all these invasive procedures, but he was willing on a day-to-day basis to sleep all day, or to not feel the best if it meant it got him to 2 years, right? In contrast, a guy who is very similar to him, who is my patient, an 86-year-old who has the same heart failure, COPD, diabetes, in and out of the hospital with heart failure symptoms. And he comes for a post-hospital follow-up as well. And his, of course, we maxed out all his heart failure meds, and he has a blood pressure of 80 over whatever. And what matters to him is he's got, man, I will want to stay awake to play cards with my buddies 2 days a week. And I can't stay awake right now. I'm just falling asleep the minute I sit down. So we weaned off some of his medications to give him some more blood pressure so he could have some energy to play cards. And he knew that, maybe he wasn't going to get another month. And he didn't want hospitalization. So, he knew tweaking his meds may cause problems with this heart failure, but we were going to deal with that on an outpatient basis and give him the energy to play cards with his buddies. And we were able to do that. So I think what matters most is truly this, right? Digging deeper than advanced care plans to say, what is your goal today? What do you want to be able to do? What gives you quality of life? What I want to do, I know I'm dying, but what I want to do is play cards with my buddies, right? And some people it will be. Now, this gentleman who wanted to live 2 years, he did not make it 2 years. I think he made it about 9 months, but we had lots of discussions. And I know I never did find out if they brought the grandson back early or not. I hope they did, because we certainly had conversations that he wasn't going to make it his 2 years. So hopefully they did that. But I think that's the key to conversations about what matters most. And I think, even I read and talk and listen and learn and educate myself, but I still can have very poor discussions about end of life. It can still go very wrong. So I think it's something you have to practice and continue to practice and learn about. And so these are, I think, really good ways to learn about these things, these books, Being Mortal, When Breath Becomes Air, The Extremis or Endgame. I'm not sure which one anymore is that. Dr. Miller's, he has a hospice house in San Francisco, and one is a documentary about his hospice house. And so those are good. The Being Mortal was made into a Frontline PBS documentary that's really good as well. So you don't necessarily have to read the book. You can watch the documentary. Obviously, When Breath Becomes Air, about a physician who goes through a serious illness and death, and his thoughts from being on both sides. Then there's Patient Priorities Care, which is a website that helps you learn how to have conversations to get to what are your goals, what matters most to you today. Conversations, Ready Toolkit, there's resources, and here's some other, there's the TED Talk. The YouTube is the TED Talk from BJ Miller about his life and how he became a palliative care doctor from his life experience. Conversation Project is huge. It's where I think how we educate our advanced care planning nurses, and other Honoring Choices is another way to learn, and it's I think patients can go through it to get to what their choices are too. So it's patient and medical provider, but just lots of good resources here. And like I said, it can always go poorly, even if from the most, the people who are giving talks and even it can go poorly for them, right? So it's always something you're striving to do better at. And I think the biggest thing is just honest communication and asking the hard questions.